Okay, shall we make a start for the education session? I think the hall was just clearing after the plenary session. So welcome to the education session entitled Treatment Algorithms for Hormone Receptor Positive Advanced Breast Cancer. My name is Stephen Johnson from the Royal Marsden Hospital. I'll be chairing the session this afternoon, and we're going to have 3 talks that are going to cover aspects of ER-positive advanced breast cancer and the treatment paradigm that we now face today. The first talk is going to be from Todd Miller from Dartmouth College, who will look at endocrine resistance and what do we know. The second talk will be from Steve Cheer from the British Columbia Cancer Centre, who will look at the current treatment options that we have in the clinic and what we've learnt in terms of applying it to clinical practice. And then I'll give the final talk, which will look forward at how to overcome resistance and introduce new agents. The format will be that we'll have 20 minutes for each presentation, and then if we have a little time, we'll have a Q&A and panel discussion at the end, but we need to be out of here by 6 o'clock so you can all get a bus home for your supper. So without further ado, I'll ask Todd to start the session. Thank you.
So the major learning objectives for the first portion of this session would be to be able to describe the standard treatment options for patients with hormone receptor positive advanced breast cancer, the potential roles of ER and growth factor receptor signaling in endocrine resistance, and also the role of cell cycle defects and mutations in endocrine resistance. And we'll start with what endocrine therapies are available. So the mechanism by which estrogens function is to induce dimerization of ER, which gets phosphorylated, binds to DNA, and recruits transcriptional coactivators and drives a large gene expression program, namely cell proliferation-related genes. The way tamoxifen or 4-hydroxytamoxifen in the laboratory works is by inducing the recruitment of transcriptional co-repressors, and that blocks gene expression, although tamoxifen can have agonistic effects as well as antagonistic effects, depending on the context. And we also have aromatase inhibitors, which block the aromatization of androgens to estrogens and therefore act as estrogen deprivation therapy. And another type of therapy, of which fulvestrant is the only currently approved type, is selective estrogen receptor downregulators, or SERDs. Although the mechanism of fulvestrant is still a little fuzzy, some things we do know is that it binds to ER and blocks dimerization, and therefore blocks ER transcriptional activity in the nucleus, also promotes ER degradation in the nucleus, and ER degradation in the cytoplasm by causing aggregation, and degradation by the proteasome, and prevents entry into the nucleus. So the management of hormone receptor positive breast cancer, most patients that we see have early stage breast cancer, and they're going to have surgical resection of the primary tumor. They're going to get chemotherapy either before or after surgery. Most of them are going to get radiation therapy, and then 5 years of adjuvant anti-estrogen therapy, namely tamoxifen or a steroidal aromatase inhibitor. And the majority of the patients will be fine. Those that have recurrent disease or that progress during the adjuvant regimen, a lot of them are going to be treated with subsequent endocrine therapies. Fulvestrant is one option. Other aromatase inhibitors, such as exemestane, are an option, and exemestane is now can be combined with the everolimus based on the BOLERO-2 data. They can also recycle endocrine therapies, and we'll get into why that can happen. So they may get an endocrine therapy in a later stage, and after that, it gets kind of fuzzy as to what we can do to manage this disease. And we know that adjuvant endocrine therapy is very effective. Tamoxifen versus placebo is effective in preventing recurrence and also increasing overall survival. And aromatase inhibitors are slightly more effective than tamoxifen, at least in some studies, in preventing recurrence. So the most common scenarios of endocrine resistance that are seen are de novo resistance to all endocrine therapies, and these patients will typically progress fairly quickly. Some are de novo resistant to some, but not other endocrine therapies, and it's still an open question as to why that may be. Some have initial response to endocrine therapy, followed by progression on that endocrine therapy, and that's termed acquired resistance. And then they may have temporary response to other hormonal therapies, but ultimately the cancer becomes refractory to all endocrine agents. And another type would be initial response to an endocrine agent, followed by progression on that agent. then transient response to the same agent introduced years later, which I would term recycling of therapies. So the preclinical data suggests that ER itself may be involved in resistance to estrogen deprivation or AI therapy in patients, aromatase inhibitors. This is an example of two ER-positive breast cancer cell line models that we had generated in the lab. LTED stands for long-term estrogen deprived, so the cells are grown in hormone-depleted medium for several weeks or months until hormone-independent populations emerge, and we term these LTED cells. And they are models of resistance to AI therapy. And we see that in these two LTED lines, there is upregulation of ER protein levels compared to parental controls. And counterintuitively, what we found is that when we treat these LTED cells, which are growing without hormones, with fulvestrant at a dose which is achievable in culture but not achievable in patients, we use it at 1 micromolar, which would downregulate ER, we get inhibition of growth. And if we use siRNA to knock down ER expression at the RNA level and at the protein level, we see that there is inhibition of growth of the LTD cells. This suggests that they're engaging ER to grow in the absence of hormones. And similarly, if we take the parental ER-positive breast cancer cell lines and we grow them in hormone-depleted medium for weeks or up to 2 months, we will see hormone-independent clones emerge. But if we culture them chronically in the presence of fulvestrant, in 3 of the 6 lines that we tested, we see that there's an inhibition of the emergence of hormone-independent cells, again suggesting that ER is functioning in the absence of hormones. We took 2 of the LTD lines and treated them plus or minus fulvestrant and performed gene expression microarray analysis. And we see that genes that are normally upregulated by estradiol treatment were downregulated by fulvestrant and vice versa. So this suggests that the same genes that are being regulated by ER and estrogen under estrogenic conditions are being regulated by ER under estrogen-independent conditions. And if we treat these cells with fulvestrant, we can see a decrease in ER transcriptional reporter activity. What this means is that the baseline or bottom of ER transcriptional activity is lower than we were seeing in the absence of hormones, and that ER is retaining hormone-independent activity. So we looked to see if this could happen also in human tumors. In a pre-surgical study where patients were getting treated for 2 weeks with the aromatase inhibitor letrozole, in the surgical specimens, we can consider them hormone deprived because this time frame is sufficient to maximally suppress estrogen levels. We performed chromatin immunoprecipitation for ER. The first step in that process is to cross-link ER to DNA, fragment the DNA, and immunoprecipitate the ER with an antibody, and then we can PCR for DNA fragments that are bound to ER. So this gives us a measure of DNA binding activity of ER. And using those tumors, in 2 out of 3 tumors, we see that there is increased ER DNA binding activity compared to control. And also, interestingly, those 2 tumors that had high ER DNA binding activity had high residual Cas67 levels after 2 weeks of letrozole therapy, and the high Cas67 levels have been correlated with shorter time to recurrence. So this hints that the residual ER activity in those tumors may have been driving the residual cell proliferation. And indeed, we see that ER expression is frequently retained in endocrine-resistant tumors. These are 2 different studies that compared primary and relapsed or metastatic lesions. And we have an ER or PR positive to negative rate of 5% and negative to positive rate of 9.4%. So 14.4% of the time we see a change in ER status. That means that in 85% of patients, the relapse retains ER or PR and does not change. And in this study, they separated from either a decrease in ER or an increase in ER, and it happens 10% of the time. So that means 90% of the time, the ER status is the same. So ER is retained and therefore may continue to be worth targeting upon recurrence. And this is a study from a few years ago by Dr. Johnston that looked at tumors that were acquired at the initial biopsy and then upon relapse following tamoxifen treatment. And some of these patients had been treated with surgery and some had not. But interestingly, we see that those that had acquired tamoxifen resistance had retained ER, whereas those that were de novo tamoxifen resistant upon relapse, their ER was virtually gone. So this gives us tells us something about the mechanism that may be involved in acquired versus de novo resistance. And we know that fulvestrant can be effective as one example of a weight line therapy, weight line endocrine therapy. Fulvestrant can be effective in patients with recurrent or advanced disease. This is data from the CONFIRM trial where patients were treated with either low or high dose fulvestrant, and there was a slight increase in PFS in patients that were treated with the high dose compared to the low dose. But the point I wanted to make here is that the objective response rates and clinical benefit was nearly 50% in the high dose arm, suggesting that treatment with endocrine therapy, even though the patients have progressed on a prior line of endocrine therapy, can still be effective. And fulvestrant use in the clinic, we see that there is an overall clinical benefit rate in this analysis of roughly 48%, and it can still be used as a later line of therapy, and there can still be response, even out to the third, fourth, or even fifth line of therapy. I put this in here because it is worth mentioning that we may be using high-dose estrogen therapy in some contexts, and this is gaining a little more attention recently, but it's fallen out of favor over the last several years, but now it's coming back. Using high-dose estrogen therapy for advanced breast cancer. The mechanism by which this works is not quite known, and I think that's the reason it's being shied away from. So this is some very old data done by Dr. Engel's group, where patients with advanced breast cancer were treated with diethylstilbestrol, which is a synthetic estrogen, or tamoxifen, and they basically had the same time to treatment failure, or basically the same overall survival. And importantly, if we look at those that had complete regressions or partial regressions, we see that the numbers are low, but surprisingly, if patients were treated with a synthetic estrogen, which is counterintuitive to the use of anti-estrogens, we do see that 40% of them have regression. And a more recent study done by Matt Ellis's group showed that they compared low-dose and high-dose oral estradiol in advanced breast cancer, and it did have an effect in some patients. It does have an effect, but it's counterintuitive as to why you would treat with high-dose estrogen when we're trying to also treat with anti-estrogens. So why high-dose estrogen works is still an open question, but may be an option. Moving on to the role of growth factor receptor signaling pathways and endocrine resistance, we know that there can be crosstalk between the estrogen receptor and growth factor pathways in sort of a positive feedback fashion, whereby PI3 kinase and MEK, the effectors downstream of them, can phosphorylate ER to promote ligand-dependent and independent transcription activity, and also ER drives the transcription of genes that encode growth factor receptors and their components via positive feedback signaling. In an effort to determine mechanisms of resistance to estrogen deprivation or AI therapy, we profiled the LTD cell lines that we had made for different pathway markers, and we found that there was increased phosphorylation of P70S kinase and phosphoate KT compared to control cell lines, and this is the case in all 4 cell lines. This is a marker of mTORC1 activity and a PI3 kinase activity. This suggested that there's increased PI3 kinase mTOR activity in LTD cells compared to parental cells, and indeed when we treated with inhibitors of those pathways, we abrogated the endocrine-resistant growth of the LTD lines. Also looking in human breast tumors, by reverse phase protein array analysis, we profiled PI3 kinase pathway markers in 64 primary ER-positive HER2-negative breast tumors. And by hierarchical clustering, the patients fell into 2 main clusters, which returned PI3 kinase high and PI3 kinase low, based on the expression profiles of their PI3 kinase pathway markers. When we separate these 2 clusters and perform Kaplan-Meier analysis, we see that all the recurrences happen in the PI3 kinase high cluster and none happen in the PI3 kinase low cluster. While this is not may not be reflective of a treatment of advanced disease, this suggests that you may be able to detect PI3 kinase activation in the primary tumor and predict whether the patient is going to recur or progress on an adjuvant endocrine therapy. And to determine whether targeting PI3 kinase and ER simultaneously is worthwhile, we performed an experiment in mice bearing MCF7 breast cancer xenografts treated with either fulvestrant or the pan-PI3 kinase inhibitor BKN-120. And we found that the individual treatment slowed tumor growth, but the combination did induce regression in all the mice. The PI3 kinase pathway is the most frequently mutated pathway in human cancer, and breast cancer is no exception. the most commonly mutated gene is PIK3CA, of course. While you don't get PTEN mutations much in ER-positive breast cancer, you do get loss or decrease of gene expression and therefore protein expression, and you can also have HER2 amplification in some cases. IGF-1R insulin receptor is expressed, although not mutated, sometimes overexpressed, maybe just expressed. But these are all putative targets that are being looked at right now. And we're also looking at the Cancer Genome Atlas data for those same genes across 324 primary breast tumors that were classified as Lumina A and B in the Nature paper on this cohort. We see that there are some overlapping mutations, but also a lot of tumors that have just one mutation, namely the mutation of PIK3CA. But overall, if you group these mutations together, 74% of them have a lesion somewhere in the P. ethicans pathway at the genomic level. One of those examples would be FGFR overexpression. Alan Ashworth group found that FGFR1 amplification, which lies upstream of PI3 kinase and other pathways, promotes endocrine resistance in these cells which have FGFR1 amplification. If they were treated with siRNA to knock down FGF1R, it sensitized the cells to tamoxifen and caused a leftward shift in the curve. And similarly, in the SUM44 cells that also have amplification, if you knock down FGFR1, you sensitize to tamoxifen, and you also block the effect of the FGF2 ligand. FGFR1 copy number also predicts for shorter distant metastasis-free survival in patients. And along in the same families, FGFR4, which is a homologue of FGFR1, and in this study they also found that if you had higher FGFR4 expression, you had shorter PFS in patients that were treated with tamoxifen as a first-line therapy for recurrent disease. Moving on to the cell cycle defects and their involvement in endocrine resistance, we know that aberrant activation of the CDK4/6 pathway circumvents the need for ER. So E2F is a family of transcription factors that drive cell cycle progression, namely E2F1, 2, and 3 drive the G1 to S transition. E2Fs are activated by phosphorylation of RB. When RB is not phosphorylated, it binds E2Fs and inhibits them. This phosphorylation event is mediated by CDK4 and 6, which binds cyclin D to be active. And working upstream of this, there are several inputs to activate CDK4/6 and cyclin D, but one of them is our nuclear hormone receptors, namely ER, PR, and AR, which can drive cyclin D expression, among other things. So if you have aberrant activation of CDK4/6 or cyclin D1 amplification or loss of P16 or P21, you dispense with the need for ER and the pathway is considerably on. Genetic lesions in this pathway occur in about 27% of ER-positive breast cancers, although it remains to be determined whether those lesions are sensitizing to this drug or not. The data that I think Dr. Johnson will discuss says that there's a possibility that these genetic lesions may not be biomarkers. But we did find that their ER-positive cells are sensitive or hypersensitive to CDK4/6 inhibition. So the CDK4/6 inhibitor that is farthest along in development is PD033291, and in this analysis done by Richard Finn and others across a panel of roughly 50 breast cancer cell lines, the luminal or ER-positive cell lines had the lowest IC50 to this drug, whereas the basal or triple-negative cell lines were relatively insensitive, and the reason for the insensitivity is still an open question. And also in an analysis that we did, we screened a kinase library against siRNA library against 779 kinases in both the MCF7 LTD and parental MCF7 cells, all under hormone-depleted conditions, and we find that knockdown of CDK4 was the top hit in these cells and the third highest hit in MCF7 cells, supporting the notion that CDK4 is important for endocrine resistance. And we find that when we knocked down CDK4 in all the cell lines, all the ER-positive cell lines, that inhibited the hormone-independent growth, while fulvestrant was only effective in some cell lines. And the same was shown pharmacologically with the CDK4/6 inhibitor or fulvestrant. These cell lines do not care about fulvestrant when hormones are not present, meaning their ER is not functional in the absence of estrogens for whatever reason. But they still do respond very well to CDK4/6 inhibition, suggesting that The reliance of ER-positive breast cancer cells on CDK4/6 is driven by their lineage, not driven by their whether their ER is functional in the absence of hormones or not. In mice with MCS7 xenografts, we treated with fulvestrant or the CDK4/6 inhibitor, and both of them slow down tumor growth. The CDK4/6 inhibitor caused virtual cytostasis. I opted to leave out a section on biomarkers associated with the response to targeted therapeutics in these pathways because there's much data being presented at this meeting in other forums on biomarkers that may be associated with the response in ongoing trials. In conclusion, ER may remain active in tumors with acquired resistance to endocrine therapy, and continued endocrine therapy is warranted in such patients, namely those that had a prior response to endocrine therapy at an earlier stage. The PI3K/mTOR pathway inhibitors are effective in combination with endocrine therapy. Something that needs to be noted is that almost all patients with advanced ER-positive breast cancer progress. So very few patients are cured with these therapies, so we need more curative agents instead of just managing a chronic disease. And also aberrant activation of CDK4/6 signaling circumvents the requirement for ER to drive cell cycle progression. Thank you.